Hello, everyone, and welcome. I'm pausing just a moment as I see all the participants being let into the webinar. But in the interest of time, I am Laurel Sprague. I lead the Community and Youth Engagement Division for UNAIDS, and it's really my pleasure to be moderating this webinar today. I would like to welcome all of you. I see a lot of people joining. It's lovely to have you here. And before we start, I want to give a big thanks to the International AIDS Society who have organized this and brought us together. It's going to be an excellent webinar, with particular thanks to the IAS Heart of Stigma team, who we can thank for this event. So moving quickly, because we only have 1 hour together and a really excellent group of speakers and panelists, what I would like to just say briefly with my organizational hat, this session that you're going to hear today is specifically about moving from evidence into advocacy. And I think we could have the next slide up already. Moving from data to action, evidence to advocacy, how communities are using evidence-based advocacy to reduce HIV-related stigma and discrimination. And this, again, with my organizational hat, is absolutely demonstrating the ways in which communities of people living with HIV, networks of women living with HIV, specifically PLHIV and women living with HIV-led networks are working and showing the way to reach the 10-10-10 targets, UNAIDS Global AIDS Strategy targets, which are moving us toward a world free of criminalization, violence, and stigma and discrimination, and also the 30-60-80 targets, particularly the 60 targets, which say that communities, which means PLHIV, key population, women and youth-led networks, should be supported to lead 60% of the advocacy toward these enabling environments. So it's really exciting to see in concrete terms exactly how communities are leading the way to do that. So I think let's go directly to the next slide, and I will let you know who are the incredible panelists that you will be hearing from today, both speakers and panelists. We have Maurine Murenga, who is a pioneer of the movement for young women and adolescent girls living with HIV in Kenya, and a longstanding fierce advocate for ending pediatric HIV. She is the executive director of the Lina Me Foundation and the coordinator of TB Women Global. She's a board member of UNITAID, an IAS mentor, and a faculty member of the IAS Advocacy for Cure Academy. So big welcome to you, Maurine. We also have Adama Ouedraogo, who is a psychologist and the coordinator of the National Network of Associations of People Living with and Affected by HIV in Burkina Faso. He has 15 years experience working with communities, including as the coordinator for the implementation of the People Living with HIV Stigma Index 2.0 in 2020 in Burkina Faso, and has worked to for a national plan to eliminate stigma, which we will hear more about. And finally, Edwin Bernard from the HIV Justice Network. He is the founding executive director of the HIV Justice Network, which is a global advocacy organization playing a leadership role in combating HIV criminalization and convening diverse partners to resist punitive legal and public health responses to people living with HIV. He's also the global coordinator of the HIV Justice Worldwide Coalition. I expect that these three esteemed colleagues are well known to many of the people who are joining the call. And I think you'll be as excited as I am to hear from them. So if we could go to the next slide, I'll go over the program so you know what to expect over the next hour. Shortly, I will finish speaking and we will have a presentation from Maurine Murenga. Moving from that to a video from Zimbabwe. And I can tell you it is a video from the People Living with HIV Stigma Index showing the work by the Zimbabwe Network of People Living with HIV to reduce stigma and discrimination experienced by people living with HIV within religious communities. After that, we will have a panel discussion with our three panelists with plenty of time, we hope, given that this is only an hour, but with plenty of time for your questions and responses from the panelists. So as we go through the presentation and as we start the panel discussion, I would ask you to already be thinking about any questions that you might have for our panelists so that we can quickly move through that section and have enough time for them to answer as many of your questions as possible. And then I will close the program at the very end. So this is what you have to look forward to. A few housekeeping notes. First, as you may notice, all participants are muted. If you have questions, we ask you to please use the QA box at the bottom of the screen and not the chat box. The QA box will be the one that we're monitoring. We will reserve time for a 15-minute Q&A session at the end. We probably should have started with this, but there is translation available in English, French, and Portuguese. You can see the button that looks like this, the interpretation button. Click that icon and select your preferred channel. I do want to note that one of our panelists will be speaking in French, so don't be confused and think that if you're an English speaker that you don't need to click the translation button if you don't also speak French. So please go ahead and find your language now, and also just letting you know that the recording will be available at the IAS platform after the webinar. Thank you. And now we go into the next slide, which I believe moves us into our presentation by our good colleague, Maurine. So Maurine, I will hand the floor over to you now, and thank you.
Thank you very much. I will ask for the sharing of the slides. Thank you. So our data-driven advocacy is dubbed robbed of choice. And this was a situation where women living with HIV in Kenya were sterilized just because they had HIV. So in January 2012, there was news in a Kenyan television news channel, Citizen, reported that there was a project called Project Prevention. It was a United States-based organization that was paying women living with HIV in the island of Mbita to have IUDs implanted or long-term family planning. Some had tubal ligation at a rate of $40. So because of the poverty rates in this area, the women were being demanded to mobilize 10 of them. So you'd come with 10 of your friends living with HIV for the IUDs and tubal ligation. And when we were having this conversation, in our support groups, women say that, but that has been happening in our hospitals. So we started having these conversations in our psychosocial support groups. And then it culminated in an event organized by ICW Eastern Africa, where we were talking about sexual and reproductive health. And we raised the issue around sterilization of women living with HIV. And they told us, oh, you're just saying it because it's happening in South Africa. And we said, no, it's happening to us as well. So as usual, communities are not trusted unless they give evidence. So we were forced to provide evidence from that actually this was happening. And then we planned a study to gather the evidence in between October and November in 2011 in Nairobi, Kakamega counties. It was led by the Africa Gender and Media Initiative in partnership with the Women Fighting AIDS in Kenya, Lean on Me Foundation, and an organization called Grassroots Empowerment Program. Next slide. So the study was very respectful, and it was supported by Open Society Eastern Africa through the Gender and Media Initiative, who are doing the documentation. And the purpose was to document the experiences of women living with HIV who had reported undergoing forced and coerced sterilization. So we focused on safety and security and psychosocial support for the study's participants. And we ensured that they were linked to our support groups, the three organizations, Lean on Me, WAFAC, and the Grassroots Initiative. So we ensured that they were in our support groups, and they received psychosocial support throughout the process of sharing their stories. The guidelines, we were also guided by the WHO guidelines on researching violence against women as part of protocol development process. So there we got relevant research permits and ethical approvals from the Ministry of Education and Kenya Medical Research Institute. Then participants who are members of our support groups. And prior to participants' recruitment, we carried out community education forums on forced and coerced sterilization with all potential participants, identified the support groups to help distinguish the participants. And the selection criteria included a woman living with HIV, 18 years and above at the time of interview and at the time of sterilization. Because we also received minors who had been sterilized and we didn't know how to handle the legal age and stuff like that. So we could not allow them to share their experiences. And then we also you had to have reported experiencing forced and coerced sterilization in Kenya and the desire to voluntarily participate in the research. So we allowed 7 days of our participants after telling them what it would be, what backlashes they expect to receive. And then the waiting period was also intended to help them process the process in their mind and ensure they don't feel pressurized to participate. So there are participants who fell off during this time after they thought it through, they were not ready to continue. And then so we pre-tested the questionnaire and we had 40 participants who shared their stories. And these stories are available, documented in a book called Robbed of Choice that can be found online. And then we also have an audio. We have a video, sorry. And the video is also dubbed Robbed of Choice. It's a 10-minute video. So the interview questionnaires had the five section: demographics, sterilization experience, rights and choices, disclosure of sterilization status, and impact on sterilization experience. We also were taking into consideration not putting pressure on women who had not disclosed their sterilization status, because we realized that when they were telling their stories, that this was a very gross violation that women were even scared of sharing and had not even shared despite having shared HIV status. Next slide. So some of the comments from the women that the whole report is online, you can find it, it's called Robbed of Choice, but I'll just quote some of the comments that they explained how they went through the process. So one of them said this was because they say that if I don't agree to undergo tubal ligation, they will not give me milk for the baby. I agreed to have the tubal ligation done since I could not afford to buy milk for the child. This was the time when women were not allowed to breastfeed. We were asked to bottle feed or formula feed our children. And that was a dangle for sterilization. So if you are HIV positive and you went to find formula for your child, they'll ask you to get sterilized first before they give you the formula. Then one was told that they are only positive. They are not only positive, but they are blind, so they cannot continue having children. And that was the reason for the sterilization. The other one, they did not get the consent from her, but from the husband. So she says, the doctor told me that after having a conversation with my husband, they will proceed to take me through tubal ligation. And then there's one who was told that she was about to die and cannot give birth to a healthy child. So they used to give us also mental experiences. So she was taken to a hospital ward that had children with the extreme AIDS-related infections so that she could decide if she still wanted to have such a child in her life or not. And that is when she agreed to tubal ligation. And then the other one also said she found herself at the hospital and they helped her deliver a child who died at birth. And during the delivery process, they operated on her and tied her tubes. And then we see this one. There are many comments, but I'll just choose a few. I was in labor when they insisted on tubal ligation. I signed the document so that they could attend to me and relieve me of the pain I was going through. I was not able to reach my husband as he had no phone. So they were even using, which was unethical, women at their time of pain. Next slide. So this is what happened to them after the sterilization process. One said, if I had known the repercussions, I would have refused because now my husband is busy looking for a child from other women. One was ostracized. They said she was a liability because she could not have children. And then someone said in the last few years, she has had suitors, but had to stop relationships because if she gets married to them, then she'll be abandoned when they discover she cannot have children. And then there's the one who says, I was not able to tell that I'd been sterilized because I had a cesarean procedure. Others only found out when they were trying to have babies and they could not have babies. So they went for further examination and they were told, oh, you've had tubal ligation. And that's when they realized, oh, maybe it happened when I was having my baby. They were not informed. So another woman says it's really painful because she has seen other women who are HIV positive get healthy children while she's not able to. So it was a really painful experience. Next slide. So we litigated in 2012. And no, it wasn't in 2012. In 2012, we started the process. And it was the 2012 report by Gender and Media Initiative, the one I've told you, robbed of choice. It formed the basis of the court case. We took the report to Kelly and asked them to see if, because we tried having conversations with healthcare providers and the policies and stuff. And then we realized that Kenya had very progressive policies that did not allow for such a practice to go on. And so because we didn't know where else to redress, we decided to litigate in court to stop. Our initial process was that the court should rule that the practice should be stopped. So even by 2012, we still had cases of women being forced or coerced into sterilization. So the report presented testimonies of 40 Kenya women who had been sterilized. So Kelly met with these 40 women after the launch of the study to verify their cases. And in the verification, you know, lawyers, they want strong evidence that they can take to court. So some women did not have like written evidence on, they were looking for a lot of evidence, including the clinical reports and stuff like that. So some women did not have the cards they used in the hospitals they went to. And the hospitals would not give the records because they knew why we wanted the records. So it is only, we found for 5 women. And these are the 5 women that we that agreed to go. There were more than 5, but it's only 5 who agreed to go to court. And we thought that this was sufficient enough to use their case to stop the whole practice amongst the general population of women living with HIV in Kenya. Next slide. So the justification we used, apart from the hospital records, we also used other instruments that protect women living with HIV. So we have the Constitution of Kenya 2010, Article 43, that states that every person has the right to the highest attainable standards of health, which include right to healthcare services, including reproductive healthcare. And also Article 29 is about not subjecting people to torture in any manner, whether physical or psychological. We also use the Kenya National Family Planning Guidelines for service providers that emphasizes on informed and voluntary consent prior to female surgical sterilization. So the guidelines is very, it emphasizes the care that must be taken to ensure that every client who chooses this method does this voluntary, is fully informed about the permanence of the method and the availability of alternate long-acting, highly effective methods. We also use the UN Human Rights Committee that monitors compliance with the International Covenant on Civil and Practice Rights, ICCPR, that refers to sterilization of women without their consent as a violation of the right to be free from torture and other inhuman and degrading treatment. And finally, CEDAW, providing right to access to specific educational information, including information and advice on family planning in Article 10H. So we also added this into the litigation to help us get justice. Next slide. So 9 years after the filing of the case and consistent advocacy and support for the women in court, we had, it wasn't just the Women's Network that litigated. We had other organizations from outside Kenya, including ICW Global, ICW Eastern Africa. We had UNAIDS and joined the case. So we got really a good support in the litigation of this case. So there was the court, after 9 years of constant mentions and hearing and support and advocacy, the court delivered a landmark judgment that forced sterilization of 4 women living with HIV constituted, they remained 4. One of them had to drop in the process. 9 years was a long time, and they felt drained, so they dropped. So 4 continued with the case to conclusion. So they said forced sterilization of the 4 women living with HIV constituted a violation of their fundamental rights, including dignity, freedom from discrimination, the right to a high sustainable standard of health, and the right to establish a family. So the judge awarded the petitioners damages, borne, and from the different hospitals they went to. There was Marua Maternity and Nursing Home, the county government of Nairobi, MSF France, Pumwani Maternity Hospitals, and Mary Stopes International. So the judge firmly established that women living with HIV possess the inherent right to make informed choices regarding their reproductive decisions. So it mandated all medical facilities to uphold the paramount importance of obtaining informed consent from patients who seek medical treatment in their premises. The court also dismissed, we had also sued the Cabinet Secretary of Health for Kenya and the Attorney General because they said that the state already had implemented a comprehensive legal policy framework to ensure the robust procedures for obtaining informed consent. Next slide. So what are the lessons? What were the lessons learned? So this is just one of the typical day in the mentions where women living with HIV would support those that are going to court. We would gather, get briefs, and we would, so that we understand the procedure. Whoever is talking to us is a lawyer from Kelly. So women living with HIV and their allies accompanied those that were involved in the case with every visit. So that kind of support is, because sometimes the courts are very intimidating, and so that kind of support was very helpful. And then we had media coverage, and we also supported the media to do respectful reporting, because sometimes media can further stigmatize people. So we supported them in terms of the language and how to respectfully report around this. Advocacy continued. We had consistency in messaging and consistency in the support of those of us who are in court. We had data and evidence from medical records, and this was really, really helpful, because in areas where we did not have the data, the women were unable to litigate. So that was really, really helpful. But there was also a negative impact in that women living with HIV who went to hospital for tubal ligation were denied the services. The doctors would tell them that they don't want to be sued, so they can only give them condoms. And so that was the negative impact from the whole process, that even women who really wanted the tubal ligation, so long as you're living with HIV, they don't give you the services. They say you will sue them. Next slide. So I want to acknowledge the three ladies who spearheaded the study, collecting of evidence and leading the process. We had Teresia Njoki Otieno. I'm putting the organization she was working with then. She was working with Women Fighting AIDS in Kenya. Later, she became the board member of ICW, and now she's in Athena, I think. And then I also was working in Lean On Me Foundation then. And then we have the late Inviolata Mpoavi, who was then, when we began the process, working at Grassroots Empowerment Trust. But by the time of the ruling, she was with ICW Kenya. Oh, she's the late now, but later she moved on to ICW Kenya, but continue with the process. We ensured that forced and coerced sterilization became everybody's business. So we talked about it with every opportunity we got to speak in panels, in technical working groups of government. Everywhere we went, we talked about it. Then we helped to also shift the debate on non-consensual sterilization from private arena of our psychosocial support group to the public domain. And then next slide. So we also want to thank Open Society Foundation. They supported the project. And then we had Namibia Women's Health Network campaign to end forced and coerced sterilization of positive women. So what the Namibian network did is they set a precedent and inspired us to share our own experiences on non-consensual sterilization. And then we had the amazing Dr. Anne Kihara, who is a consultant and a lecturer at Nairobi University, obstetrics, gynecology department. Her word was very, very important to us, because she acknowledged that sterilization is happening, and that it should stop, and it violates human rights. Coming from a government doctor, it was very, very important. Gender and Media Network helped us to document the stories and to share them. And then Kellyn for providing pro bono legal services and stayed on to ensure that we had received justice. That was in 2023, December. So I think that is the end. Thank you very much, everyone. Over to you.
Thank you so much, Maurine. If I could just say in this moment, as one positive woman to another, how grateful I am for the work that the women in Kenya did. It matters for all of us. It's really a powerful story. And I'll let the people listening know that there will be an opportunity to hear more from Maurine during the panel and to ask some questions during that time. So with that, I think we can move directly into the video from Zimbabwe. I'll ask my colleagues to start the video for us. Thank you. Colleagues, I don't hear any sound. Should there be sound? Yes. So, Aditi, IAS folks, there's no sound coming through. I wonder if there's a quick fix. If not, let's go quickly to the panel discussion and perhaps we can show this at the end. Okay, there's the sound.
Ndinomirira vana like ku guidance and counseling ndichivadzidzisa magariro atingaitewo. Zvakare ndiri focal person we-HIV and AIDS stigma reduction and discrimination. Munhu ari kurarama ari HIV positive. Asi ndakanga ndisingakwanisi kuita open up. Mai vangu chaivo zvakanditorera nguva kuti ndivaudze. Because mai vangu munhu uye aitaura zviri negative about vanhu vanorwara, because munhu aishanda muhospital aiona zvakawanda. And vanhu vamwe vanenge vaine mentality yekuti kana munhu uri HIV positive maybe unenge uchiita zvekuita zvevarume vakawanda kana kuti zvekupinda pinda.
The People Living with HIV Stigma Index has been widely recognized as an effective tool in monitoring stigma and discrimination among people living with HIV within the community. And it has been used to inform policy development and also HIV service delivery. At the same time, the participants of the Stigma Index study are also empowered by the process and benefit from networking as well as a referral to health services that they may be needing.
The Stigma Index research that was carried out was beneficial really in that it prompted the church into action. We then said and agreed to say we will continue with the focal persons who are at the schools and now train them on stigma and discrimination reduction.
Saka kutrainwa kwataitwa taidzidziswa kuti zvii zvinosanganikwa nazvo nevanhu mumacommunities even mumaschools. Uye kana vanhu vasangana nemasituations iwayo like zvekusarudzwa tinopinda sei pane pacho pazviri kubvira kuti tigone kudzidzisa kuti vanenge vachiita kakusarudza kachekako vaonewo kunzwisisa pamusoro pemaconditions eHIV and AIDS nekudzidziswa kwandakaita neruzivo rwandanarwo through Stigma Index program iyi. Ndamunhu ava empowered akugona kusangana nematambudziko uye nekutodzidzisawo vamwe kuti vanokwanisa kuzvimirirawo sei nekugara kwakanaka. Ende toda kutenda Mwari kuti this program even mumachurches munopiwa time yekuti kana uine zvakutaura 1 minute or 2 minutes wototaurawo uchidzidzisawo vanhu vari muchechi imomo zvokuti even kana vakazonzwa kuti mainhingi vari kurarama neutachiwana vanokuakomodheta havazokusarudzi. Vana vangu vavawo kuzivawo kuti mangwana havachasangani nesituation idzodzo nekuti vanenge vaakuziva zvekuita through ruzivo rwandakavapa rwandakawanawo inini.
Wonderful. And I see that that video will be also made available if people want to watch it again, and maybe pick up the sound in the beginning that we missed. So what I would like to do now, we'll move into our panel discussion, and I will ask Adama, Edwin, and Maurine, if you could turn your cameras on so we can see our wonderful panel. There will be questions for everyone, but I also, we're halfway through the webinar, so I already see questions coming into the Q&A. So we'll keep this session a bit short and move to the Q&A questions a bit earlier than planned in order to make time. But where we will start now is with Adama from Burkina Faso, I believe. Let me see if Adama has his video. Thank you. Merci, Adama. So Adama, the first question that I have is for you about your work in Burkina. And the question is, I understand that you were involved in the shaping of the National Strategic Plan against HIV-related stigma in Burkina Faso. This is such an important piece of work for all of us to learn from. Could you explain to us how you used data to strengthen your advocacy for this national plan against stigma in Burkina Faso? And to remind participants, I believe Adama will be responding in French. Thank you.
Bonjour, merci beaucoup de me donner la parole. Je suis Adama Ouedraogo, c'est monsieur Adama. J'ai entendu madame Adama, comme ça porte, le nom porte à confusion souvent. Et merci déjà pour la question. Il faut dire qu'au cours de l'année 2020, nous avons eu à réaliser l'indice de stigmatisation 2.0 au Burkina Faso. Et les données assez poignantes nous ont quand même permis d'avoir de faire d'abord du plaidoyer pour avoir un plan d'élimination de la stigmatisation. Voilà. C'était assez important puisque, d'autant plus qu'au niveau national, la stigmatisation et la discrimination persistent beaucoup. Et selon l'indice de stigmatisation 2.0 réalisé, on était à plus de 13% de stigmatisation enregistrée auprès des personnes vivant avec le VIH-Sida et des populations clés également. Et donc, avec l'objectif, les 3-10 de l'ONU-SIDA, nous avons essayé de faire le plaidoyer. Les 3-10 de l'ONU-SIDA, c'est-à-dire au moins de 10% de stigmatisation, discrimination des personnes vivant avec le VIH, moins de 10% encore de violences basées sur le genre, et aussi que les pays aient voilà, des lois répressives, moins de 10% de lois répressives au niveau des pays. Donc, avec tous ces éléments, nous avons croisé le secrétariat permanent du Conseil national de lutte contre le VIH-Sida, qui nous a d'abord accompagnés même dans l'étude. Nous avons pu montrer les résultats et avoir leur accompagnement, prendre comme allié pour le plaidoyer. Nous avons encore croisé l'ONU-SIDA avec ces données et nous avons eu alors un bon groupe d'alliés avec les autres acteurs de la société civile, bien sûr. Et nous avons fait un plaidoyer auprès du Fonds mondial pour pouvoir mobiliser des ressources afin d'élaborer un plan d'élimination de la stigmatisation et discrimination au Burkina. Et je peux vous dire que c'est une première, avoir ce type de plan d'élimination de la stigmatisation au Burkina Faso. Donc, ça n'a pas été facile, mais nous avons au moins pu mobiliser les ressources et nous avons pu élaborer ce plan. Et ce plan nous a également servi lorsque nous étions dans la phase d'écriture de la subvention du Fonds mondial GC7, parce que c'était déjà un document reconnu, validé, et c'est ce document qui a permis de l'élaborer, en tout cas, de prendre en compte les activités qui étaient en lien avec la stigmatisation et discrimination des personnes vivant avec le VIH-Sida, qui a permis aussi d'arrêter les activités sur les questions de droits humains, genre, et sur les questions de violence basées sur le genre. Voilà un peu ce que je peux dire là-dessus. Donc, c'était bienvenu et ça nous a permis vraiment d'avoir des actions que nous avons inscrites dans la demande de financement GC7 pour le Fonds mondial au Burkina Faso. Merci.
Thank you very much. This is so inspiring to hear not only about the National Plan Against Stigma, but the inclusion of important elements related to gender-based violence. Really grateful for your input. I have one follow-up question for you at the moment, which is about the laws criminalizing people living with HIV in Burkina Faso. Is it correct that those laws, the HIV criminalization laws, have also been amended? And was there evidence of stigma and discrimination used to bring the change in the laws?
OK, je vous remercie pour la deuxième question. Il faut dire déjà que la loi portant protection des personnes vivant avec le VIH-Sida au Burkina Faso a été validée en 2008. Donc, on l'appelle la loi 030 en 2008. Et son décret d'application a été mis sur le terrain en 2010. Donc, à la suite de tout ça, nous avons vu qu'il y avait des articles quand même qui criminalisaient. Et donc, nous avons demandé une relecture de la loi. Et la relecture de la loi date de bien longtemps. Et donc, à la suite aussi de l'étude Stigma Index, nous avons encore, si vous me permettez l'expression, réchauffé le dossier. Et donc, on avait quelque chose de poignant sur la main avec des argumentaires. Et nous avons vu le SPCNLS autour des années 2020-2021 pour révéler le dossier de relecture de la loi. Donc, il y a eu le DNP+, qui nous a encore accompagnés avec des ressources pour le plaidoyer. Et nous avons revu l'argumentaire avec les acteurs de la société civile et avec le SPCNLS, dont nous nous sommes retrouvés, on a revu l'argumentaire et nous l'avons partagé au SPCNLS. Il faut dire que chez nous, lorsque, il y a un projet de loi, il faut revoir tout ce que vous voulez revoir et donner à votre structure, mais qui va se charger de faire véhiculer le dossier jusqu'à l'Assemblée nationale. C'est comme ça se passe. Donc, l'argumentaire a été partagé au SPCNLS qu'il a envoyé au ministère de la Santé. Et donc, nous avons suivi le dossier. Et juste il y a quelques mois, nous avons encore été interpellés par le SPCNLS et le ministère de la Santé sur ce même dossier. Et nous nous sommes retrouvés en atelier à 100 km de Ouaga pour revoir avec le nouveau conseiller du ministre, puisque le ministre a un conseiller volet juridique. Donc, nous sommes retrouvés à 100 km de Ouaga pour revoir tous ces articles que nous avons trouvés criminalisants et aussi en parcourant également les lois des différents pays de la sous-région, tels qu'en regardant sur les lois de la Côte d'Ivoire, regardant sur la RDC, etc., 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 du Bénin, qu'est-ce qui était mis dedans afin que lorsque le dossier va arriver au niveau du COTEVA, c'est le comité technique de validation des lois, qu'on ne nous ramène pas encore en arrière. Donc, on l'a fait et à Ouagadougou, on a encore revu les choses et on a échangé avec nos partenaires techniques surtout tels que l'ONU-SIDA, sur des éléments qui étaient difficiles, ou bien encore comment avoir les idées et s'orienter sur ces mêmes articles avec les différents pays pour ne pas qu'il y ait des écarts. Et aujourd'hui, le dossier complet a été transmis auprès du ministère. Et je pense que cette fois-ci, c'est sur de bonnes voies. Pourquoi je l'ai dit? Déjà, le ministère a dépêché son conseiller technique pour nous accompagner. Et après le travail à Koudougou, nous sommes revenus à Ouaga. Nous avons encore travaillé à peaufiner le document et le réintégrer au niveau du ministère de la Santé. Et donc, qu'il a envoyé au niveau du comité technique de validation. Et nous attendons vraiment cette phase finale là, de la loi. Sinon, ce que nous avons commencé depuis plus de 6, 7 ans, on pense que c'est maintenant que nous sommes sur la bonne voie parce qu'on a eu vraiment l'accompagnement et on a compris beaucoup de choses. Beaucoup de choses. Nous, bon, en tant qu'acteurs de la société civile, on a notre vision de ce qu'il faut faire, voilà, mais avec des techniciens même de la justice qui nous ont accompagnés, voilà, on a compris beaucoup de choses. Eux aussi, ils ont compris, voilà, qu'est-ce que le VIH, et voilà comment, pour le dépistage, etc., etc. Parce que nous, en tant qu'acteurs de la société civile et en tant que juristes, on n'a pas les mêmes manières de voir les choses. Donc, ce travail-là nous a permis de tout aplanir et avec aussi les lois des différents pays que nous avons parcourus, je pense que nous sommes sur la bonne voie. Merci.
Congratulations and thank you so much for this effort. This is incredible. And I think highlights, as we saw from Maurine, the importance of being steadfast, of having resilience and being willing to fight over the long term for such big structural changes. And I hope you will win in Burkina Faso. This is important. Let me now turn, and I think this is a perfect segue. Let me now turn to Edwin Bernard from the HIV Justice Network. And I'd like to ask you, I know it goes a little bit back in history, but I'd like to ask you about the expert consensus statement that you led, the expert consensus statement on HIV criminalization. I know it was a very long process. I remember some of it personally. Can you tell us why that was such an important initiative and how data was used to help shape that statement?
Yeah, thanks, Laurel. So as we've already heard from Adama and Maurine, strategic litigation or law reform can take such a long time. And one of the things that we do at the HIV Justice Network, we have a global HIV criminalization database, and where we monitor the laws and prosecutions around HIV criminalization. We've done this for quite a long time. And it was very clear to us that something needed to be done to ensure that many of the prosecutions that we were aware of for either alleged non-disclosure or potential or perceived exposure or for alleged transmission were really unjust. The courts were not understanding science. And obviously, over the years, science has evolved really phenomenally particularly around understanding risk of transmission, the treatment's impact on the risk of transmission, and also treatment's impact on life expectancy. And there's also been an evolution in the understanding of the limitations of science in proving who infected whom. And all of those things, it was very clear from our community-based monitoring that the criminal legal system, the judges and the prosecutors, courts, and obviously juries and the media reporting on it, had no idea about the incredible evolution in science, and we needed to do something to ensure that criminal legal actors understood science. So we began, I think, the conversations in 2014 with UNAIDS to begin with, to say it was important that there was a document that courts could rely upon, and particularly expert witnesses in courts could rely upon, to highlight issues around science, around risk, harm, and proof. And so we worked with UNAIDS for several years, and then we brought in the IAS and also the International Association of Providers of AIDS Care, IAPAC. And what we decided that the key thing to do was to find the global experts on HIV science and convene them. Remarkably, I think the group of the 20 experts, the lead author is Françoise Bertsounozy, the Nobel Prize-winning scientist. I think there were 5 or 6 current or former IS presidents, and they came from all regions of the world. And we spent a number of years through this process educating them about what was going on in courts around HIV criminalization, so they could understand how to write a statement that was not looking at risk from a public health perspective. It was looking at individual possibility of particular sexual acts, and also spitting and biting. There were these horrendous cases of people being sent to prison where there was absolutely no risk and no harm, whether it was sex or whether it was spitting or biting or other kinds of minor assault. And so this process obviously used all the up-to-date science. They reviewed all of the science and ensured that the information in the expert consensus statement could be applicable and in criminal legal system in the courts. And yeah, it wasn't a difficult process. It was just a long process to get the consensus, to ensure that it was written in a way that courts could understand. And yes, and it was launched in 2018.
Thank you so much. And I think it's such a model for advocacy that can be used in other areas where people living with HIV and other marginalized groups face such unjust use of criminal laws. I wonder, since the time is really ticking, since it's been almost 6 years, or yeah, almost exactly 6 years since the expert consensus statement was launched. I wonder if you could give maybe just one example, because I see so many questions come in, but maybe one example of how this has contributed to improvements in laws and policies since that time.
Yeah, well, there are so many, and we published last year a 5-year impact report on the impact of the expert consensus statement, which you'll be able to download from our website. I'm sure they'll share the link. I mean, it's been remarkable in so many different ways. Obviously, used as defenders in court and for all kinds of advocacy campaigns. I'm going to highlight the case of Lesotho. So Linda Gale Becker, who was one of the authors and a former, I think she was the IS president at the time, provided was an expert witness in this really problematic case in Lesotho, where a man living with HIV who was found guilty of rape was then tested for HIV, found that he was positive, and he faced the death penalty simply for living with HIV. Of course, he should have been prosecuted for rape, but the HIV status led to the idea that that the risk was so great that he should be put to death. So Linda, there was an appeal, of course, and Linda Gale provided a really important testimony about the harm of HIV, how because of in the context of treatment, HIV is not an automatic death sentence for people who acquire HIV, and therefore courts should not apply a death sentence, and that appeal was successful. And there have been many similar cases around risk and also around the limitations of proof.
Thank you so much for that succinct answer. I know it's not easy when there's been so much good advocacy and so many successes. What I'm going to do quickly now is turn to Maurine. And Maurine, I'm going to start now asking questions that are coming in through the chat. And so the first question for you comes from Ace Robinson and saying hello to Ace. What he is wondering is if you were able to evaluate the impact of the media coverage, saying we've seen media coverage even done without stigmatizing language can both help but also hurt our efforts, and would love to learn more best practices for public engagement via media. I wonder if you have a response for Ace, Maurine.
Yes, I do. Thanks, Ace, for the question. Really critical. I think for us, when the case was first reported, it went south because people were wondering why women living with HIV are insisting on having babies, yet they can infect the babies. So it made women living with HIV and those of us involved in the case even look bad. And so with time, we held trainings and cafes for media just to let them understand from our point of view why this was important. The tone of their reporting and how the tone was important and the language was important. After that, we got some positive vibes, but it's never 100%. Sometimes the reporting goes south. So throughout the case, we had instances where people would tweet very unkind things, and nowadays media is open to everyone because of social media. So anyone can go there and have a big audience and say whatever they want to say. So in as much as we got some, after the training, making friends, talking about the tone and the language, we got some allies we were sure who are very influential, that we were sure if they wrote, then people would have a meaningful conversation around the case. So that helped. And then later the U is equals to U narrative even helped further. We did not incorporate that in the court, but it really reduced the level of stigma that people had for women living with HIV. So I think it's never 100%, but there's always efforts to make sure it works to some extent. We don't have a one bullet for it to show that this really works. Yeah.
Super, thank you so much. I think that's helpful, and it's such a brilliant question. Perhaps we need to have a whole webinar on the use of media. I think we're all eager to learn from each other about this. Let me now actually ask a question that I think first goes to Adama. But then after that, I think both Edwin and Maurine will also have some useful inputs, and this may be the last question we have time for. So we'll see where we are after the end of this question. But first to Adama, so this, just to give you a heads up, this is a question about the context of insecurity. And we know, I think many of us, some of the challenges you're facing in Burkina Faso. So in the context of insecurity, how can community actors be effective in the fight against discrimination and stigmatization, given the other challenges that you're also facing? I know it's not an easy question, but we'd really love to hear from you, and then also from Edwin and Maurine on this, if you could give us your thoughts. Mr. Adama, over to you.
Merci beaucoup. Effectivement, dans un contexte d'insécurité, il est vraiment difficile d'être toujours proactif et de réagir, parce que les priorités, c'est pas la question de la stigmatisation, discrimination. Mais déjà, n'empêche que nous sommes un réseau d'associations et nous couvrons tout le pays. Donc, nous sommes dans les 13 régions et nous travaillons dans la communauté avec nos coordinations régionales et avec nos associations au niveau terrain. Et ce qui est bien, c'est que dans toutes les régions où nous intervenons, même où il y a des difficultés, mais les populations ou encore les PEVIH sont rattachés à nos associations et au niveau des coordinations régionales. Donc, nous arrivons à réagir à temps quand le besoin se fait sentir. Nous appuyons surtout pour les examens, voilà, les examens, les ordonnances pour la prise en charge, pour l'accompagnement quand nous avons des vivres pour eux. Et lorsqu'il y a des besoins en termes des violations de droits, tout ça, c'est relevé par nos acteurs et nous confions ces craintes, ces plaintes à des professionnels des droits. Et nous avons une organisation au niveau du Burkina Faso qu'on appelle Juriste Express qui accompagne surtout les personnes vivant avec le VIH et les populations clés sur les questions de violation de droits et sur les questions de stigmatisation, de discrimination. Et même quand on était dans la relecture de la loi, ils étaient avec nous, ils nous ont accompagnés avec leur vision, leur expérience. Et donc, cela nous permet quand même, partout où nous sommes au Burkina Faso, puisque nous sommes un peu délocalisés un peu partout, et quand nous avons des préoccupations, quand nous avons des besoins pour nos populations, nous réagissons rapidement. Voilà. Et notre couverture du territoire nous permet de réagir à temps également. Donc, cela ne nous empêche vraiment pas de travailler. Et une anecdote, il y a des endroits au Burkina Faso où il fut un moment, il était difficile même d'envoyer les intrants, les ARV. Et nous avons travaillé. Et il y a eu ces difficultés qui nous sont remontées par nos associations dans ces zones-là. Et donc, nous avons travaillé à récupérer les ARV au niveau de la Camargue ici. Et nous avons vu avec l'ONU-SIDA, avec le PAM, pour héliporter ces ARV pour nos populations, c'est-à-dire à Djibo, à Pama, tout ça. Donc, nous sommes proactifs sur ça, si c'est ça, peu importe la situation. Et comme nous sommes dans la communauté, comme nous avons des remontées d'informations chaque fois, et nous arrivons à réagir. Cela peut se vérifier avec l'ONU-SIDA et comment nous envoyons les ARV dans les zones difficiles et comment nous avons envoyé encore d'autres intrants. Et aujourd'hui, même dans les zones les plus difficiles, nous arrivons quand même à nous déplacer et à faire le dépistage précoce des enfants nés de mères VIH+. Donc, on a vraiment un bon maillage du territoire et on s'en sort. Merci.
This is truly impressive. Thank you very much. I think I can speak for all of us that we're wishing you all of the best in this context. So thank you for this. Let me turn next to, I'll go in the same order, to Edwin and then to Maurine for any thoughts as well on this question about the challenges of working in context of insecurity. Edwin?
So I'll just say very briefly, highlighting the importance of regional and global networks. If it's unsafe for you to do work in your country, if it's unsafe for you to advocate from within your country, then that's when regional networks and global networks like ours, I think, can really help support advocacy, law reform, and connect you with the relevant people to give you the support. So, and obviously really a key enabler of global and regional networks is the Robert Carr Fund that funds us and many others. And we really appreciate that. So that, I think, is a key thought for me.
Yes, thank you so much. I think that's critical. And I'm pulling these a few key things together, but let me first turn to Maurine for also any final thoughts that you might want to share about this difficulty of working in context of insecurity.
I think in context of insecurity, I agree with the regional efforts, but also to sufficiently resource the communities that are experiencing the difficulties so that they can be able to push from within and to influence from within. Sometimes power imbalance is reduced when you invite people to your space, and this requires resources than you going to their space. So yeah, that could also be a process.
Brilliant. Thank you all so much. I hope all of the people watching this webinar are as inspired as I am right now. I want to just say how clearly it came across both the resilience and the need for steadfastness continues to be the word that comes to me of advocates and people living with HIV, the importance of national, regional, and global networks, and that are fully, properly resourced and supported from the national level on up. And also the allies we have in human rights institutions, the lawyers, as well as academics and researchers that work with us. It's really a beautiful picture that comes together from all three of you. I'm afraid that we're out of time. So just in closing, I want to say, again, thank you to IAS, and also to note that this webinar is a joint initiative of the IAS, GMP Plus, and ICW, and the People Living with HIV Stigma Index partnership. Very grateful to everyone who showed up, and particular thanks to the three panelists who spoke here today. And with that, we are 1 minute over the time, and we'll have to close the webinar. Everyone have a good day, be well, and hope to see you next time.